Now, I would like to invite Dr. Rachna MEEL, our, though young but highly skilled and experienced, faculty we have in RP Center AIMS. She'll be talking about IgG4 orbitopathy.
Humbled by those words from my own teacher. Thank you so much. Yes, so before I start, I just wanted to ask how many people here are oculoplastic surgeons? Are all of you oculoplastic surgeons? How many of you do tumors or excise them? Are there any pathologists here?
Including us?
No,
You're asking?
excluding us, of course. Okay, all right. So I don't see any hands, so I think then I will just begin with I see IgG4 is something that is recent. So have you come across any patients that had IgG4? Any of you? All right. So okay, let's go on. So IgG4 related disease is something which is new and was first described recently, 2003. So there were a number of things that many patients had which we thought were unrelated, including pancreatitis, the type 1 pancreatitis, Riedel's thyroiditis, and retroperitoneal fibrosis, and also Meckel's disease. And over time, people realized that some of the patients have all these manifestations in various combinations, along with a histopathology which was unique to all of them. And they were combined with this single characteristic histopathological picture. And that's when IgG4 related disease came into existence. That was 2003. Now, this is immune mediated fibroinflammatory condition, and it is basically, do we have a pointer? It's basically characterized by three things on three characteristics: clinical, histopathological, and serological. So you have multiple masses in the body. It may be in various organs, and one of them which may be orbit or eyelid. And then again, you may have a histopathological picture. I'm not going to talk about that much. We'll touch upon it later. And I think Dr. Seema is also going to talk about it. And then, of course, you have a serological picture where you have a raised concentration of IgG4 levels in the blood. So this is just to show you what all organs can be involved. And there are a number of organs that can be involved, but the most common ones that are involved are pancreas. And in head and neck, it is the lacrimal gland. So now, why is it important to know about IgG4? And that is why I asked you first that how many of you actually do tumors? Because IgG4 can present as an orbital mass, an eyelid mass, and if we do not know about it, we will not look for it, and we will not ask our histopathologist to do a IgG4 staining, and therefore we may actually miss it. And this has a systemic association which can have an end organ damage. It can be life-threatening at times, and which can really affect the life of the patient. So we need to know that an IgG4 disease can involve orbit in the form of a mass whenever we are excising a mass. And the second reason is that some of us may also think that it's a malignancy. So it's not a malignancy. It's not a lymphoma. It is a lymphoproliferative disorder which has a characteristic presentation, which has a characteristic increase in plasma cells, all of which are IgG4 positive, but it is not a malignancy. So now that brings me to the diagnostic criteria. The first diagnostic criteria was given in 2011 by Umhera et al. And then this was again revised in 2020. And then also the pathology team came up with a consensus statement on this in 2012. And then, of course, the Rheumatology Society came with another one. And there was also the organ-specific criteria, which I think Dr. Bhavna touched upon in her first presentation. So let's talk about the diagnostic criteria that was given by Umhera et al., and which is what is most commonly used to make the diagnosis. So what do you have is you have swelling or masses in multiple organs. So we as ophthalmologists will come across a patient who's coming to you with proptosis or an eyelid mass. And when you are doing excision or an incision biopsy, what you characteristically find is a plasmolymphocytic infiltration along with some amount of fibrosis, which is also evident clinically when you see the patient. And the tumor, if you can palpate it, is quite firm. and that is indicative of fibrosis. And then, of course, there's an infiltration by plasma cells, which are positive for IgG4, but that you will only know if you do a IHC for it. If you don't do a IHC, they are simply plasma cells lying there. So it's a plasmo lymphocytic infiltration that the pathologist will see. And until and unless you ask the pathologist, he will not look up for IgG4 positivity in these cases. The other thing is the elevated serum IgG4 concentration, which is said to be raised specifically in these cases if it is more than 135 mg per dl. So not any increase is increased enough for quoting it to be associated with IgG4 disease. It has to be greater than 135 mg per dl. So if you have all these three, then we call it a definite IgG4 related disease. But if you have a combination of clinical and just the pathology, then it is probable. And if you have a clinical with serology, it becomes possible disease. So now what modification was made in this criteria in 2020? So when first the diagnostic criteria was given, a lot of other specialities came out with organ specific criterias, and those organ specific criterias were added to the diagnostic criteria, and there were certain remarks that were added specifically when we were making a diagnosis, one of which was the requirement of a biopsy. So if you have an increased IgG4 level, you cannot just assume that the patient is having IgG4 disease. The other thing is many cases of malignancy were missed out and misdiagnosed. So as far as possible, one should try to do a biopsy to get the diagnosis. Then, of course, they also remarked about the serum IgG4 levels, which could be raised in a number of other diseases, the systemic inflammatory diseases, and you have to rule out those systemic inflammatory diseases before you quote it as a IgG4 disease. So a certain number of other things were added as a word of caution so that misdiagnosis would not happen. And an organ specific criteria was also given for ocular disease, which included, I mean, it was essentially what I've already talked about, but what was highlighted was that sometimes you may not find fibrosis in an orbital case of IgG4, and also you might find some germinal centers which is specific to orbital disease, and you may not find it in other organ when they are involved in IgG4. Other than that, the criteria for the number of cells per high power field has been very variable. While it was 10 in the first diagnostic criteria, in the organ specific criteria, they said 50. And if you look at the consensus of the pathologists, they are saying if it is more than 100, even in absence of fibrosis or a dense lymphoplasmacytic infiltrate, even on an absence of those two, if you have a IgG4 positive plasma cells more than 100 per high power field, you can say that it is highly suggestive of IgG4 related orbital disease. So I think that is more of a pathologist's purview. But coming back to clinical side, epidemiology wise, this affects middle aged people and has a male preponderance, and it has a biphasic progression with an initial inflammatory phase followed by fibrotic. I will not go into pathogenesis. Let's talk about orbital disease. So the mean age is again 55 years. The male-female ratio is not as high for the orbital disease as systemic disease. And the most common orbital structure involved is lacrimal gland. So you may have a patient coming to you with bilateral lacrimal gland enlargement who may be having IgG4. Rarely, the optic nerve may be involved, orbital bone, but those are rare case scenarios. Now, this is really interesting. So, if someone has a IgG4 related disease, only 4 to 34% will have an orbital involvement. So, if you have a known systemic disease, 4 to 34% may have an orbital involvement. But if a patient has ophthalmic disease, then almost 80% of those patients will have systemic involvement, even at the time of presentation or maybe later on. So you need to screen these patients again and again for other organ involvements, and that's why you need to diagnose it correctly. And this is more so when you have bilateral involvement or a lacrimal gland involvement. So again, we need to know whether it is IgG4 or not. Bilaterality in orbital disease is almost reported in 60%. So unilateral IgG4, is it really unilateral? Go back and see the radiology. You may be missing it on the other side. More than 50% are actually bilateral. How do you look for rest of the organ involvement? do a PET scan. There are no guidelines, but this is good. It helps you to find out rest of the organ involvement. I have only 20 seconds, so I'm just going to go on to the, I'll just quickly go through the imaging findings. So these have been described, like lacrimal gland enlargements, extraocular muscle enlargements, and then again you could have, yeah, this is something very characteristic. This is the infraorbital nerve in the infraorbital canal, and this is enlarged, and this is thought to be sort of characteristic for IgG4 disease. So if you see a extraocular muscle enlargement along with this, think of IgG4. And yes, how is it different from pseudotumor? We keep on talking about orbital inflammation, and people keep on saying a lot of orbital inflammatory disease is now IgG4 actually. How is it different? So extraocular muscle involvement in myositis typically involves tendons. IgG4 does not. The other thing, myositis is painful. IgG4 is not. Myositis in fact involves the medial rectus, the superior rectus. IgG4 involves the lateral rectus. So those are some things which may help you to, start thinking of IgG4. Active disease will require treatment. Sometimes if a structure like optic nerve is involved, you might need emergent treatment. Asymptomatic patients, you can just follow them up. So just follow them up, screen them for rest of the organ involvement, and that's about it. Treatment typically is with steroids, and it is so responsive to steroids that if it is not responding to steroids, then you should go back and look at your diagnosis. That is what the Rheumatology Association says, and a lot of other people say, that if a case of IgG4 is not responding to steroids, go back, check your diagnosis, because that is rare. We usually start with 0.6 mg per kg per day, and then of course it is tapered, but it has to be a slow taper. That is what you have to remember. Remissions are good, but relapses are 30 to 70%. I think in a previous presentation, I think it was Dr. Bhavna, and she said 70% of them actually relapse. So relapse rate is high. And what do you do if a case relapse after you've given steroid? So you could try a steroid therapy again. That is the first thing that everyone does. And if that does not work, or the patient is having severe side effects, that's when you start disease modifying anti-rheumatic drugs. And there is some data on use of rituximab. This is the only drug that can be used alone for inducing a remission. So DMARDs, when you're using, that has to be in combination with steroid, but rituximab standalone can be used for inducing remissions. I will not go into this. So now the risk factors: male patient, young age onset. I'll not read all of them. Lacrimal gland involvement is a risk factor for recurrence. So if lacrimal gland is involved, there is a risk of recurrence. That is something that we have to remember. And let's see. So this is the data that we have seen over the past 5 years. Yes, most of our patients are male. And most of the patients are in 21 to 60 years of group. Proptosis is the major presentation. Inferior extracorneal space is what we found was mainly involved. These are just some case pictures. So this patient came to us with redness along with a little bit of a proptosis and limitation of extraocular movements in upgaze. And you can see there is a mass infraorbital compartment along with an enlargement of this infraorbital nerve. And he responded very well to steroids. This is another patient. Again, bilateral redness with pain. Looking closely, he had PUK. And then when you look at the imaging, you see there is a mass here, which is showing some peripheral so this is T2, so this cannot be enhancement, sorry. I don't know why it just keeps going forward, yeah. So this is the enhancement here, and this is the fibrosis which causes it to be dark on T2, so which shows that it is a fibrotic lesion. And look how well he has responded to steroids. His serum levels were more than 135. Again, another case, very good response to steroids. This was a childhood case which presented to us at 24 years of age, and he came to us with a vision loss in the less affected eye, which is this eye. And he responded beautifully to steroids again. And most of the times they will just stay good once they've responded. They may not have any activity for a long time. And then another one here, of course, surgical excision was done, but it showed IgG4. So that was just to show you the spectrum of patients that we have seen. So the take-home message is that IgG4 related disease should be considered. in a differential diagnosis of any long-standing orbital tumor which is not having any pain. And biopsy actually is important to rule out malignancy as well as to make a diagnosis in this case. IgG4 positivity is non-specific. It can happen in systemic immune disorders. So don't overdiagnose. Be careful with your diagnosis. And it has a good response to steroids. And most importantly, once you make a diagnosis, follow up the patient to see if he has other